Now, uh, esophagogastroduodenoscopy. Esophagogastroduodenoscopy is used to evaluate the esophagus, stomach, and the duodenum, and can diagnose esophagitis. Sorry, and can diagnose peptic ulcer disease, esophagitis, and esophageal cancer, among others. The patient has a feature suggesting of esophageal and gastric cancer given unintentional weight loss, upper GI bleeding leading to occasional dark stool, ibuprofen and other non-steroidal anti-inflammatory drugs NSAIDs can cause gastric irritation, gastric mucosal irritation leading to upper gastrointestinal bleeding and should be stopped in the setting of epigastric pain and dark stool. Upper GI bleeding in the setting of malnourishment and unintentional weight loss should be evaluated directly with esophagogastroduodenoscopy. Gastric cancer may be gastric cancer classically gastric cancer classically presents with weight loss, early satiety, and melena in a patient with a history of smoking, peptic ulcer disease, chronic gastritis, or frequent consumption of nitrate containing food. Okay.
Okay. Next. 67 men comes to physician because of 6-month history of increasing difficulty walking. He has not had pain or numbness. He has no history of serious illness or recent infection. Exam of the lower extremity shows atrophy, muscle strength is 3 out of 5. Bilateral deep tendon reflexes are increased in the lower extremities. Sensation is intact. Which of the following is the diagnosis?
So what is your diagnosis?
I guess ALS.
Yes. If there is like muscle atrophy, lower motor neuron and deep tendon reflex increased upper motor neuron. So both upper motor and lower motor neuron diagnosis done ALS mostly.
Mhm.
Okay. Amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. Okay, is a is a progressive neurodegenerative disorder typically beginning in the mid life that affects the both lower motor neurons arising from the anterior horn cell of the spinal cord and upper motor neuron from the lateral corticospinal tract within the brain and the spinal cord. Neuron degenerates as a result of neuron degenerate as a result of unknown cause that may involve RNA processing. Like sudden electricity fall of your computer, isn't it harming your laptop?
Sudden what?
Like
Didn't get
a for sudden stopping of your computer, like sudden shutting down of the computer, isn't it harming your laptop?
I don't know. I feel like my battery it lasts less. You
Okay,
know.
it does not show like any notification like your battery is dying.
No, it just
Oh,
like I
that's
no.
why.
Yeah, no. I have to look it here up there to see like how why it is. Yeah. But yeah, I didn't plug it yesterday. That's also true. And then I had class this morning with my tutor and I didn't plug it. I think that's why. Yeah. Okay. Am I
Yes,
okay? Okay.
amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis is a progressive neurodegenerative disorder typically beginning in the midlife that affects both lower motor neuron arising from the of the anterior horns of the spinal cord, and upper motor neurons of the lateral corticospinal tract within the brain and the spinal cord. Neurons degenerate as a result. Neurons degenerate as a result of unknown cause that may involve RNA processing and excitotoxicity, and gliosis results. Patients presents are available. Oh, sorry. Patients presentation are variable through typically feature a combination of upper motor neuron and the lower motor neurons is an asymmetric distribution that may involve the valvar muscle. Some patients may experience cognitive and behavioral changes through others through other through though other patients are cognitively normal. The diagnosis primarily clinical but may be supported by electromyographic findings of acute and chronic denervation and renervation. Acute and chronic denervation and renervation, along with the nerve conduct study showing reduced compound muscle activation, CMAP, maybe caused by denervated and atrophied muscles. MRI of the brain and the spinal cord may be performed to rule out the disease. Treatment should include riluzole, which may modestly improve survival but does not cure the disease. Okay?
A 14-year-old girl brought to the physician because of 18-hour history of.
Like in amyotrophic lateral sclerosis, mm, uh, respiratory failure may be the cause of death.
Mm-hmm.
So
Mm-hmm.
we do the spirometry to see the respiratory rate or
Mm-hmm.
FEV1.
Mm-hmm.
Which
Yeah.
one?
I
Or
think it's spirometry.
okay.
Mm.
And
But
for there is another thing like in lung transplant, like in sorry, not lung transplant, like in lung resection surgery. For there is another thing like FEV1 is seen
mm,
for see the prognosis, like there is thing like that. To see the prognosis, we do the FAV1.
okay, I don't
Maybe
understand your second question. What was the question? I don't understand.
the question was the patient having lung resection surgery,
Mm-hmm.
and before lung resection surgery, we are doing an investigation to see that that patient is able to continue after the lung resection.
Mm-hmm.
So on that case, FAV1 is done.
FEV1. Okay, yeah.
So if you find, maybe you have found this question, we have done it. We
I
both have
remember
done.
that one. I don't remember the ALS one. I don't remember exactly. I mean, unless you're sure it's spirometry, but I feel like there was something else for the ALS one and the respiratory issues, but
Yes,
I don't.
ALS1 maybe spirometry or FEV1. There may be specific.
Yeah,
Okay.
there was a specific thing. I just don't remember it right now. But for the long resection, yes, I think you check the FEV1 Wait, was that the APV one first
Or maybe there
or
are
the
two
T?
marker, FEV1 and DLCO, but FEV1 is more specific as far we remember.
Hmm. And I remember what you this you're saying. I just don't remember. I know they were. I know we saw those questions. I just don't remember what were the.
That is the problem happening nowadays.
Okay, the question was before
Lung
long
resection.
section, what respiratory test should you do? I guess. Um, spirometry FEV1,
And
FEV2.
DLCO also.
No, this is too much. There was one specific that was
I
what.
think that on that question, I have seen the FEV1
Yeah.
specifically. Mm, Maybe uh, spirometry, but DLCO was not the option as far I remember.
Oh, they're saying that the most important values you do spirometry, but in the spirometry, the most important values that you assess is FEV1 and FVC. So if these values is specifically the predicted postoperative FEV1. So it's FEV1, yes.
So predicted one is FEV1. Okay.
FEV1. And then what was the other question? It was the
In ALS,
in uh-huh, sclerosis, like what how do I ask that? What respiratory I don't even know. Um, mm, should be done. I guess it's spirometry.
okay. Then it is spirometry. Okay.
Okay.
These things are confusing. That's why I ask
Yeah,
you.
yeah, I know. And I remember doing the questions. I just cannot remember.
And
And
like I want to add another thing. Like in ALS, mostly we know the one drug. Can you tell me the name of the drug?
oh, Lorizon or Lorizon, Lo,
Sorry,
the
Riluzole.
Riluzon.
Riluzole, which reduces the glutamate-induced excitotoxicity, isn't it?
Yes.
And there are other two drugs also, like
Oh,
edaravone, 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 and tofersen, edaravone and tofersen. And in neuromuscular respiratory failure, we can give first line treatment is non-invasive positive pressure ventilation, NIVV. That's one. Yes, edaravone and tofersen. Tofersen. I don't know drug. Usually these things do not come, but
yeah, I never heard about those ones. The Riluzol is the one because it rhymes with the Roladi, whatever thing.
okay.
Mhm.
Okay, then ALS is completed.
Got it. 14-year-old girl brought to the physician because of 18-hour history of persistent right lower abdominal pain. She has not had fever, vomiting, diarrhea. She has no serious history of illness or of surgeries. Menarche was at 12, and menses occur at regular 28 days interval. Last menstrual period was 2 weeks ago. She is not sexually active. Temperature fine, pulse fine, respiration fine, BP fine. Abdominal exam shows mild tenderness with guarding over the right lower quadrant. There is no distension and bowel signs are normal. The remainder of the exam shows no abnormalities. Hemoglobin concentration is, I guess, fine. Uh, And leukocyte count is fine with normal differentiation. Urinalysis shows no abnormalities. Abdominal ultrasound shows a small amount of fluid in the pelvis. Which of the following is the most likely diagnosis?
Okay, small amount of fluid in the pelvis. Okay, that is the differentiating part. Okay. In Mittelschmerz, uh, is a common Mittelschmerz is a common cause of abdominopelvic pain in females. The Mittelschmerz is a uh, common cause of abdominopelvic pain in females and is caused by peritoneal irritation of an enlarging ovarian follicle or its rupture during eggs release. It commonly presents with mid-cycle unilateral abdominal pain associated with mid-abdominal tenderness in patients with regular menstrual cycle. Regular menstrual cycle, as the pain as the pain is secondary to normal physiological hormonal changes and not pathologic. Vital signs and results of the lab studies within the normal limit. While ultrasonography is not necessary, it is often ordered as Mittelschmerz can mimic appendicitis. If completed, it would be expected to show a small amount of free fluid in the pelvis, secondary to follicle rupture, as seen in this patient. Okay, why it is not ovarian torsion? Because sudden severe lower abdominal pain can cause uh, ovarian torsion also, isn't it?
Mm-hmm.
But ovarian torsion comes with the nausea, vomiting, sharp pain, and nausea, vomiting. Okay, ovarian torsion is caused by twisting of the ovary, often its ligamentous attachment, with resultant compromise of its blood supply, leading to ovarian ischemia. Patients present with sharp pain, patients present with sharp severe unilateral lower abdominal pain accompanied by nausea and the vomiting. The absence of blood flow to the ovary would be expected on ultrasonography. Okay.
Okay. Next. 62 men who underwent right below the knee amputation 36 years ago comes to the ED because of a 1 month history of ulcer at the end of the residual stump. His amputation was the result of injuries he sustained while serving in the military. He says his protective circuit has fell loose and has been rubbing recently. During the past 6 months, he has had progressive difficulty walking because of sharp pain that radiated up his leg. The pain has been occurring earlier during his walk. It slowly improves with rest. He previously walked 1 mile daily for exercise and could walk several miles without stopping. He has not had vomiting, fever, chills, or malaria. He has type 2 diabetes treated with diet. 1 month ago, A1C was 6%, vital signs normal. Exam of the right lower extremity shows mild redness and 1 centimeter also with depth of 3 millimeters over the anteromedial aspect of the limb. There is viable soft tissue and margins are clear. The limb is warm, popliteal pulses are 1 plus. In addition to recommendation for non-weight bearing and avoidance of direct pressure to the sawatos, which of the following is the most appropriate next step?
Okay. Pressure injury, also known as, can you hear me?
Yeah.
Okay. Pressure injury, also known as decubitus Ulcer is a pressure injury, also known as decubitus ulcer, is a common complication in patients who utilize a limb prosthesis. In most cases, the injury can be managed. In most cases, the injury can be managed conservatively by avoiding aggravating factors and direct pressure to the site. For this patient, a recommendation for fitting the prosthetic socket is appropriate given his report of the prosthesis feeling loose and rubbing recently. Several factors can contribute to an ill-fitting prosthesis, including changes in weight and body habitus, variation in activity levels and mobility, and general wear and tear on the unit. General wear and tear on the unit. The reason of skill, the reason of the skin interacting with the prosthesis is subject to high amount of moisture and and shear forces that result in pressure injury. Additional complications include infection, of which this patient is not displaying concerning signs and symptoms. Close follow-up is recommended to ensure appropriate healing of the wound and for monitor for developing infection.
Next, the 40 man comes to the physician 6 days after noticing non-painful lump in his neck. He also has 2 week history of palpitation. He's otherwise asymptomatic. He has no history of serious illness, no medication, temperature fine, pulse is high, respiration fine. BP is fine. Exam shows 1.4 centimeter firm thyroid nodule. His serum TSH concentration is less than zero point zero 0.05, which I guess is low. And serum free thyroxine, so T3 thyroxine
T3,
concentration, yeah, is high.
yes.
Which of the following is the most appropriate next step in management?
So it is a hyperthyroid.
Yeah,
Um, okay, thyroid nodule. Um, um, okay, discovery of a palpable thyroid mass. Discovery of a palpable thyroid mass by a patient at home or during a routine clinical visit is a common occurrence, and the diagnostic workup focuses on ruling out of malignancy. Risk factor for thyroid malignancy include young age, radiation exposure of the head and the neck, family and a family history of the thyroid cancer or associated congenital neoplastic syndrome. Men too. All patients with a new nodule should be evaluated. All patients with a new nodule should be evaluated with a serum TSH measurement, and if the TSH concentration is low, a radioiodine uptake like thyroid scintigraphy, a radioiodine uptake like thyroid scintigraphy should be ordered, and if the uptake scan is performed initially, fine needle biopsy can be avoided. Fine needle aspiration biopsy can be avoided. Subsequent workup and management are dependent upon the results of TSH measurement, ultrasonographic characteristics, TSH measurement, ultrasonographic characteristics of the nodule, and as and the results of radioiodine uptake. Okay, I want to read the other options too.
Okay.
Okay. Okay. Fine needle aspiration. Okay, there is one query.
Mm-hmm.
Uh, we have read a box, like we have
Mm-hmm.
read a flowchart, like evaluation of the thyroid nodule. On there is like TSH level and thyroid ultrasound. Then why it is not work here? But
If there is TSH.
on that on that flowchart, first do TSH level and thyroid ultrasound. Then if TSH level is low or normal or high, if TSH level is like low, like this patient, we go for radioiodine scintigraphy on
Mm-hmm.
according to that chart, like
Mm-hmm.
thyroid nodule.
Mm-hmm.
So after like doing radioiodine scintigraphy, if it is hyperfunctional, then we will treat the patient like hyperthyroid. This one, yes.
Mm-hmm.
This
Mm-hmm.
my query is this patient has not done the ultrasonography. Why we are not doing ultrasonography?
Wait, why are you doing ultrasonography? The here you said low TSH,
Yes,
then you have to do the radioactive iodine. This is what they're saying here.
but low TSH and thyroid ultrasound is present. Thyroid TSH and thyroid ultrasound, not or. You got my point. What I am trying to
Uh-huh.
mean.
Mm-hmm, 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 mm-hmm.
They do
And
not
then
say TSH level or thyroid ultrasound. They say TSH level and thyroid ultrasound. So we
what?
have done the TSH level. Then we should not do the ultrasonography. Okay, I am reading the ultrasonography option first.
Mm-hmm,
Okay,
mm-hmm,
ultrasonography of the thyroid gland should be performed in the diagnostic workup but can be done after thyroid scintigraphy as data from the uptake scan will inform whether an ultrasound guided fine needle aspiration biopsy is indicated at the time of the study.
Okay, they're saying that either way, if you have to do like is if you have to do how do I say it? Like you can just end up doing the ultrasound guided biopsy that will include the ultrasound if it's needed.
Sorry, again, can
Uh,
you tell me again?
like if you do the ultrasound guided fine needle aspiration.
Final aspiration is needed if there is like what can I say? If there is mass like lesion or if there is fluid, then we do not we don't always do the aspiration, isn't it?
But the fine needle aspiration is done with ultrasound, right?
Yes, yes.
Yeah. So they're saying that if you have to do the fine needle aspiration, you're already going to do the ultrasound there. So let's check first the RAYU, and then if you have to do the ultrasound, then you can do it with the fine needle after. That's what the question is saying. Now I don't, based on the flowchart you write, it should be the thyroid, the ultrasound first, and
If you
then
look at
the
the question,
yeah.
then this they are dealing with the hyperthyroid, not the hypothyroid, like
Hyper.
hyperfunctioning or hot nodule, isn't it?
Yeah. Mm-hmm.
So in hyperfunctioning on or hot nodule, they told us to straight go to the treatment according to
Okay.
the flowchart.
For hyper functioning, they told us to. Yeah, but you have to do the RIO, right?
Yes,
You always have to do the
if you
RIO.
do after doing radioiodine uptake,
Mm-hmm.
if it is hyperfunctional or hot nodule,
Mm-hmm.
Say,
Mm-hmm.
then we are treating the patient. We do not
Yes.
need to do the like ultrasound
Yes.
guided
Yes.
final
Yes.
aspiration biopsy.
Yes.
If it is
Yes.
hypofunctional or cold,
Mm-hmm.
or if it is like hypothyroid, then we need to have
Uh-huh.
ultrasound guidance,
Uh-huh.
final aspiration. Okay,
Yes, and-
there is a
But look at that.
yes. Okay,
Okay.
yes,
Here it says consider fine needle based on size and ultrasound findings. Um, but then the ultrasound findings kind of work only if it's a cold nodule or if the TSH is elevated. You get what
yes,
I'm saying?
yes, yes, yes.
Yeah. So in like I put that the heart nodule, you really don't need to do the ultrasound
Ultrasound,
finding.
yes.
Yeah. So you
So
see what I'm
that's
saying?
why, yes.
Uh,
Okay, I got it.
yeah. Yeah. I
So
think they just put thyroid ultrasound here because you can still use it for cold. So that's why they put it here. But really, the ultrasound is just for these two. It's not for
yes.
this one. Yeah. Okay.
Okay, now I got it.
Okay. Okay. Next. Previously healthy 24 man comes to the emergency department because of a 12-hour history of increasing pain to the left of the center of his chest, so to the left of the chest. Initially, the pain was mild and occurred only when he breathed deeply. Now the pain is more severe and constant. He rates the pain like 8 out of 10. The pain increases when he lies on his back, decreases when he leans forward. Okay.
Like
And does not have
pericarditis type of feature.
kinda, yeah. He has had no he has not had palpitation, shortness of breath, nausea, vomiting, sweating. He says that he's recovering from a head cold, which he had for 14 days. He appears in moderate discomfort, but is not in respiratory distress. Temperature is fine, pulse fine, regular respiration fine, but BP is high. Exam shows no abnormalities, including the cardiovascular. Serum creatinine kinase is it high? I don't
Sorry,
know. The creatinine
creatine
kinase is
kinase probably
four,
high.
yeah, and with MB fraction of 12%. I don't know what MB means.
Uh,
An ECG is shown. Which of the following is the most appropriate step in
that is
diagnosis?
CKMB. Creatine
Oh,
kinase MB, like in the heart. MM is
yeah.
for muscle and BB is for bone.
So creatinine kinase is high.
Is high. Not that high, but high.
Wait, the MB one is the muscle or the bone?
MB1 is
Is
the
the
heart.
MB
A,
one is
A,
oh,
M and B, like in between muscle and bone, there is heart.
muscle and bone. Oh, okay.
CK has three types, as far I remember, like CKMM, CKMB, and CKBB. So MB goes for the heart, uh,
Mm-hmm.
as far I remember. Okay, forget it.
No, I
Unimportant
mean,
information.
no, it's good. It's important because here we know that then there is a problem with the heart. Then. Mm-hmm.
This is problem with heart, but it is not acute like acute MI type of feature. And
Okay.
like look at the lead one, look at the lead one of the ECG. Looks like chair pattern, like you can sit on the lead
Mm-hmm.
one. So
Mm-hmm.
this type of pattern in lead one to this type of pattern may be found in pericarditis.
Mm-hmm.
So in
And,
pericarditis or like pericardial effusion, uh, the next thing you need to do to confirm is to do the echo.
mm-hmm.
Okay, echocardiography is indicated for the assessment. Echocardiography is indicated for the assessment of pericardial effusion in the setting of potential myocarditis. On the potential myopericarditis, pericarditis classically presents with substernal chest pain, which is often pleuritic, worsens when lying and improves when leaning forward. It can occur in patients with inflammatory, infectious, or malignant condition such as viral infection, SLE, TB, lymphoma can present as complication of the myocardial infarction or cardiac surgery. On examination, pericarditis is disclosed by diastolic friction rub, described as harsh sound heard in the diastole. The condition is diagnosed clinically and supported by increased inflammatory marker such as ESR and CRP. ECG is characterized by diffuse ST segment elevation and peer depression, diffuse ST segment elevation and peer depression if not treated. Pericarditis can lead to development of pericardial effusion, which in large and quickly accumulating can result in cardiac tamponade. Echocardiography should be performed to assess Echocardiography should be performed to assess for presence of pericardial effusion, which may require pericardiocentesis for drainage. If large, overall cardiac function ejection fraction should be assessed. If cardiac enzyme biomarkers are increased, and if there is concern for concomitant myocarditis and heart failure. Treatment includes anti-inflammatory drugs like indomethacin, glucocorticoid, colchicine, and condition with similar presentation should be ruled out, such as myocardial infarction, pulmonary embolism, aortic dissection. Okay.
Here B as in boy.
Yes. CT scan of the chest can provide structural but only limited functional information about the heart, whereas echocardiography permits the structural defect, pressure, velocity, and the flow of the blood, which is important in understanding the hemodynamics associated with structural heart disease, cardiac inflammation, or pericardial effusion or temporal.
Next. 21 men brought to the ED by paramedics because of 10-hour history of altered mental status. The mother says the patient was fine last night. This morning he did not wake up at his usual time. When she went to check on him, she could not get him to wake up. He has no history of serious medical conditions or psych illness and takes no medication. Mother says he does not smoke cigarettes, alcohol, or use drugs. On arrival, he's lethargic but not in respiratory distress. He's responsive to painful stimuli. His temperature is fine, pulse is high, respiration high, blood pressure high, pulse oximetry or room air for oxygen saturation is 100. Physical exam shows no other abnormalities. Lab sodium is normal, potassium normal, chloride is high, bicarb is low, urea is normal, glucose is normal, osmolality, that's serum osmolality is 290. I don't remember what if that was fine or not. And then urine, glucose, none, ketones, a lot, triples. Arterial blood gas, pH is, what am I? pH is normal. Yeah. PCO2 is low and PO2 is normal. Which of the following is the like diagnosis? Osmolality of the serum. I think it's normal. I don't remember what was the normal one again.
There is
Hmm.
3 plus.
Okay,
Okay.
alternate status. Okay.
Okay, I'm reading the explanation.
Mm-hmm.
So pH, like salicylate poisoning in large doses. Uh, Salicylate poisoning in large doses resulting in respiratory alkalosis. It can cause both metabolic acidosis and respiratory alkalosis, isn't it?
Mm-hmm.
Okay. So salicylate poisoning in large doses results in respiratory alkalosis from the stimulation of the respiratory center causing hyperventilation, and subsequently it results in development of delayed anion gap. Subsequently it results in, so initially it causes respiratory alkalosis,
Mm-hmm.
then metabolic acidosis,
Mm-hmm.
secondary to deep coupling effect on the electron transport chain, resulting in increased anaerobic metabolism, the production of lactate and ketoacidosis. The production of lactate and ketoacidosis be, beyond the acidic properties of salicylic acid itself. It does not always affect sodium and potassium concentration. Patients with salicylate toxicity will present hyperventilation. Patient with salicylate toxicity can present with hyperventilation, gastrointestinal upset, hyperthermia, tinnitus, agitation, delirium, hallucination. Management of salicylate toxicity involves management of salicylate toxicity involves systemic alkalinization with sodium bicarbonate infusion. Patient may need dialysis. Patient may need dialysis in the setting of severe altered mental status, end stage renal, end stage end stage kidney disease, and pulmonary edema and or clinical deterioration.
Can you read
Okay.
all the other answers?
Yes, alcoholic ketoacidosis is induced by excessive alcohol intake that results in increased ketone production and high anion gap metabolic acidosis without hyperglycemia. It would not typically result in it would not typically result in respiratory alkalosis such as salicylate poisoning. Diabetic ketoacidosis occurs as a result of the accumulation of serum ketones such as beta hydroxybutyric acid, acetoacetic acid, acetone in the setting of deficient insulin signaling. Lab studies typically show increased glucose, ketone, and high anion gap caused by accumulation of unmeasured anions in serum. Ethylene glycol toxicity results from metabolism of ethylene glycol by alcohol dehydrogenase. Two toxic metabolites include glycolate, glyoxylate, oxalate. Patients present with acute kidney injury, metabolic acidosis crystals on urinalysis, methanol toxicity results. Similarly, toxic metabolite including formic acid that can cause visual disturbance, retinal edema, optic disc hyperemia, gastrointestinal distress, putaminal hemorrhage, and neurologic depression. Ethylene glycol and methanol toxicity can cause increased serum osmolarity and an osmolar gap.
Next. 25 men brought to the ED 1 hour after sustaining gunshot wound to the abdomen. He has pain at the bullet entry. He is awake, alert, and appropriately conversing. Temperature is high, pulse is normal, respiration normal, BP normal. Abdominal exam shows a bullet wound 5 centimeters to the right of the umbilicus. And there is moderate tenderness over the entry sites. The
Okay,
remainder
I
of
have
the
sent you something. Can you
on where WhatsApp.
in here? Mm,
Okay.
Nothing came. Okay.
Yeah, little thing.
Yes.
Yeah. Mm-hmm.
Tell me the diagnosis.
Okay, 15 girl brought to the ED 2 hours after she attempted suicide by taking overdose of aspirin. On arrival, she appears slightly agitated. Her temperature is high, pulse is high, respiration high, BP normal. Exam shows sigh-like respiration, psych-like, and diffuse mild abdominal tenderness. This patient is most likely to have which of the following electrolytes finding? Mm, overdose of aspirin or salicylate. So it's what do we say? Respiratory alkalosis and metabolic acidosis. Okay. Okay. So the answer, if she has respiratory alkalosis. Hmm. Okay. If she has respiratory, then bicar will be, well, metabolic acid, that's bicar will be low. Metabolic acidosis, bicar will be low. What's the normal bicarb? I forgot.
Normal bicarb is 22 to 28.
Okay, so
Like
this
if
two.
you uh, take one constant, it is 24.
Okay, so these two can be right. And then what did I say? Metabolic acidosis. And they just said that sodium and potassium are not affected. So the normal sodium is 135 to what? 140
Yes,
to 140. Okay. And the normal,
145.
oh, 135 to 145. That's the normal sodium. And the normal potassium is, let me open that just
3.5 to
one,
5.
3.5 to 5. Okay. To 5, right?
Yes.
Okay. And then chloride. I don't know what chloride, what will happen to chloride there. Well, is this C?
Yes, C is the answer.
Mm,
But it is quite critical. Like
yeah.
we just know that we have just come into knowledge like salicylate toxicity does not
Mhm.
affect the sodium and potassium.
And
That's why
potassium.
you distinguish these two.
That's why I
And
was about to
yes, because
discuss.
like if you just going through the respiratory
Mm-hmm.
alkalosis part,
Mm-hmm.
then there
Mm-hmm.
are like two options like B and C.
Mm-hmm. Mm-hmm. Mm-hmm.
So
That's true.
these two can be ruled out by potassium level. Like potassium is more than 5, so it is not the answer. So the
Mm-hmm.
most important take home message in this question, like salicylate toxicity does not affect the sodium and potassium, and
And even the
and
chloride, it doesn't
yes,
affect the.
even the chloride may be higher. Chloride is 95 to 109 as far I
Yeah,
remember.
chloride is
Look at
95 to 105. Yeah. So here, the answer you say is C. So chloride is normal.
okay,
Mhm.
chloride is normal then. Okay, sodium, potassium, chloride, everything is normal. Only
Everything
bicarb,
is normal except, I guess, the CO2 and the bicarb. Okay.
CO2 and bicarb, yes.
Okay. Got it. Got it. Got it. Yeah,
And
that was.
salicylate toxicity can usually it initially causes respiratory alkalosis. In the later on, there is metabolic acidosis.
Yeah,
According
that's
to
what I was trying to figure out in this question. Like, what? Where are we? Are we at the respiratory alkalosis, or are we at the? But I guess it doesn't matter in this question.
we are in
It's
the respiratory alkalosis,
alkalosis because it's
like
okay. So
sigh like respiration. What does it mean?
I don't know what it means. I don't know. It's respirations. Deeper, more rapid breathing. Okay, yeah. So I guess rapid breathing.
So rapid breathing. So we are throwing the carbon
Yeah,
dioxide.
respiration. Mm-hmm. Mm-hmm. Okay, makes sense. Okay. Next, 25 men brought to the ED 1 hour after sustaining gunshot wound to the abdomen. He has pain at the bullet entry site. He is awake, alert, and fine. Temperature is high, pulse is fine, respiration fine, BP fine. Abdominal exam shows a bullet wound 5 centimeters to the right of the umbilicus. There is moderate tenderness over the entry side. The remainder of the exam is fine. During postoperative exploration, 250 ml of succus entericus and I don't know what is it, and 8 small bowel holes are found in the abdomen. The holes are treated by resection of 12 centimeters of proximal ileum. The intestine is reconstructed with the staple anastomosis. The midline abdominal fashion is suture and closed. Which of the following methods of skin and soft tissue wound management at this point is most likely to decrease the risk of postoperative wound infection?
Okay. So delayed primary closure. Surgical site infection is relatively common complication of abdominal surgeries associated with increased morbidity and mortality. It often presents with fever, induration, and pain at a surgical site. Patient physical examination may show purulent drainage. Upon palpation of the wound, deeper abscess are possible and may be less evident on physical examination. Patient risk factor Patient risk factor for the development of surgical site infection including diabetes mellitus, immunosuppression, tobacco use, and increased age. Additionally, traumatic wound and infected intra-abdominal contents increase the risk for development of infection. Despite aggressive irrigation in this patient, delayed primary closure involves leaving the incision. Delayed primary closure involves leaving the incision open, often with negative pressure wound therapy to allow a negative pressure wound therapy to allow any underlying infected tissue to drain. This also enables surgeons to do further irrigation and debridement if necessary without reopening the abdomen. The patient presented with traumatic abdominal wound associated with perforated viscous and succus entericus in this setting of a high fever, infection making a likelihood of a blossoming infection high. Therefore, the most appropriate wound technique for this patient would be delayed primary closure to decrease the postoperative infection. Okay,
Can
can you
you read?
explain this?
Oh, um, I think they're just saying that if it's an abdominal wound and it's big and you do the surgery, just leave the the wound open. Just leave the how do you call that? How the way you access the abdomen, the scar, not the scar, but the incision. Yeah, leave the incision open. So it will drain. Usually when you finish doing abdominal surgeries, you put
Well,
little tubes,
you
the
yes.
tubes to drain it. Yeah. So instead of closing and putting the tubes to drain it, just leave the thing open so it drains open. You don't need the tubes for the. And it says that it's needed when it's big abdominal surgeries, when you open a lot the abdomen. Just leave it so it drains by itself, not with the tubes. Let me see if I can find the picture. Delayed primary closure. Mm, it would be kind of something like. I don't
like
think
we
it's that
keep
open.
like we keep the
Yeah,
wound open like this you
like this one.
okay, okay,
Yeah, like this one. You leave the, yeah, I don't know why it's so small, but yeah, you leave it open and you let it drain like that because it's going to drain. It's going to drain. If you close it, it's going to drain. So usually they'll put the tubes and it will be draining with the tubes for
tubes,
days and
yes.
days. Yeah, but they're saying since it's that big, just leave it open. I think that's just for really big abdominal things. You know. Uh,
like
yeah.
uh like big abdominal thing, if we just close that
Mhm.
thing it will need the secondary closure because the staple will
Yeah.
open.
Yeah, and it
But
will take so much time, and then you have to put the tubes, and the tubes will be draining for days and days and days because it's a big opening. So that's
okay,
what they're saying. Just, but I think this is specifically for the big one. Like if you're doing just like laparoscopic appendectomy, I don't think you need this.
yes.
Yeah, yeah, I don't think
on
you
that
need it.
on that they close the incision like
Yeah,
they close the operative field.
yeah, yeah. I don't think you need this. I think this is because they removed his intestines. They did like a big abdominal thing. That's why. Can you
Okay,
read B and C?
yes. Hand sewn suture closure of the skin is commonly used to close abdominal incision, is commonly seen is commonly used to close abdominal incision. Surgical closure allows reapproximation of the tissue which allows healing by primary intention. However, hand-sewn closure of the skin would be prevent the surgical tissue from draining in the patient at high risk for intra-abdominal infection, which may lead to intra-abdominal abscess or wound site infection. And use of skin staples to close abdominal incision. In a common method, there is evidence that staples have decreased risk for surgical site infection in comparison to hand-sewn closure as the wound is still able to drain between the staple. However, the use of staple is still inferior to delayed primary closure in preventing surgical site infection. Okay.
Okay. Next. 32 woman comes to physician because 2 week history of fatigue and increased urination. She had 5 pound weight loss despite eating more during this time. She has had 2 urinary tract infection in the past. She takes no medication, no smoking, drink or drugs. The patient is alert and fully oriented. She is 5'5" and BMI is, I guess, fine. Temperature fine, pulse bit high, respiration fine, BP low. Pulse oximetry, oxygen 100, the oropharynx is dry. Reminder of the exam is fine. Labs, sodium is normal, potassium is high, chloride is normal, bicarb is low, glucose is super high, creatinine high, a urine specific gravity, I don't remember. Bilirubin none, protein none, RBCs, yeah, uh, yeah, some of them, yeah. Five, the white blood cells a lot, nitrates positive, leukocyte positive, glucose a lot. Which of the following serum hormonal profiles is most consistent with the patient presentation?
So, what is your diagnosis?
Like diabetes, one of those diabetes ones. Is it
Complication
either, yeah, either
DK or
ketoacidosis or
HHS?
HS, yeah, HHS, whatever, HHS.
Hypertrophic hyperosmolar.
I guess it's decay. Mm,
But
okay.
uh, If we remember, if we just go through the decay and HHS, HHH, HHS has high glucose level. Then the decay, the glucose level would be near about 250 to 500. But in HHS,
Mm-hmm.
there is uh, glucose level more than 600, like 1000 go for the HHS. I don't know why it is decay.
Oh, I get what you're saying. Because here is like it's like 800, so it should be HHS. That's what you're
It
saying.
should be HHS. That's my thinking.
Mm-hmm. Okay, got you.
And they haven't told us about the ketones.
They
So,
keep no.
so there is no ketone here. Okay. Okay, I'm reading the explanation now. I don't know
Okay.
why it is not HHS.
Mm-hmm.
Decay presents with fatigue, polyuria, polydipsia, shortness of breath, tachypnea, diffuse abdominal discomfort, commonly presents with type 1 diabetes mellitus. So we know that decay comes with type 1 and HHS comes with type 2.
Mm-hmm.
It occurs as a result of accumulation of the ketone such as beta hydroxybutyric acid, acetic acid, acetone in the setting of insulin deficiency, dysregulated fatty acid dysregulation, and ketone synthesis as a result of relative state of starvation created by created by absent insulin signaling created by absent insulin signaling. Vital signs may show tachycardia, tachypnea. Vital signs may show tachycardia, tachypnea, and hypotension. Tachycardia, tachypnea, hypotension caused by severe dehydration. Lab studies typically show metabolic acidosis. Lab study typically show metabolic studies. Metabolic acidosis increase serum glucose, ketone, catecholamine, and high anion gap by the accumulation of unmeasured anions in the serum. Metabolic acidosis is accompanied by decreased bicarbonate concentration. Decreased bicarbonate concentration in the serum, and the bicarbonate is consumed in the neutralization or increase acidic molecules, hydrogen molecules in the blood. Serum glucagon and catecholamine concentration are typically increased as both are lipogenic, thereby liberating lipids from the metabolism to ketone. They are liberating lipid or metabolism to ketone and are increasing response to acute physiologic stress. Treatment includes insulin volume repletion, correction of the electrolyte, and treatment of any predisposing precipitating conditions. Okay.
Mm-hmm. Can you
In
read B? Okay.
Sorry. Yes, I'm reading the B option B.
Mm-hmm.
Decreased insulin, increased glucagon, but catecholamine is decrease on that option, but decreased catecholamine. Decay is characterized by marked increase in the serum catecholamine, likely as a response of physiological stress, as it stimulates the catabolism of the lipids. So catecholamine is like a stress hormone. So
Mm-hmm.
decay is a stressful condition. It increases the
Mm-hmm.
catecholamine, and
Mm-hmm.
insulin is low in decay, and
Mm-hmm.
the glucagon would be high.
Mm-hmm.
Okay, in decay, like I have told you that glucose is near about 250 to 500,
Mm-hmm.
and bicarbonate would be as decay is high anion gap metabolic acidosis.
Mm-hmm.
Agma, like bicarbonate would be low, anion gap would be high, ketone would be high, and if we look at the osmolarity,
Mm-hmm.
serum osmolarity should be less than 320.
Serum osmolarity.
Osmolarity should be low.
Mm-hmm.
But in HHS, look here. The glucose is okay, 300 to 800. They told here
Yeah,
in 300. Even
yeah,
if
but
even if it is 800, our target is not fulfilled. In this question, there is 1000, isn't it?
wait, this question, let me see. I thought it was, no, it's 800.
So I am seeing the urine glucose. Oh,
Oh, yeah, you were looking at the urine glucose, yeah. But yeah, it's 800.
800 is like the last portion.
Which one is the other, the hyperosmotic? How do you call that
HHS.
one?
HHS is more than
I don't know. How do you call it? How do you spell it? Hyperosmolar,
hyperosmolar hyperglycemic state.
hyperglycemic. Okay, let's see. What is it? There is not a box for it anyway. But yeah, I guess it will be higher than 800, I guess.
Yes, look at here. They have written like more than
Where?
I have just seen this. Uh, go downwards.
Mhm.
Okay, we are not finding.
Okay. I feel like there was a box for that one too. I just cannot find it.
Yes, I don't remember. Maybe
But it should be higher, right? Than
yes,
800.
it should be
Okay.
higher than 800. Maybe more than 1000.
More than 1000 probably. Okay.
And on that point, serum osmolarity would be high too. Okay.
Serum osmolality should also be high. Okay. Next. Oh, but will the insulin glucagon and catecholamines be the same?
Yes,
Okay.
both
Okay.
has
So here,
same thing, but we can differentiate like the history, like the decay happens in the type 1 and HHS is for type 2 and decay is more rapid than the HHS and the glue then and the lab finding finally the lab finding in the lab finding like ketone body is present in decay but in HHS there is a normal ketone like normal anion gap negative or small ketone. And if we look at the osmolarity, serum osmolarity, if it is less than 320 in case of DKA and more than 320 in case of HHS.
okay. So here we didn't really need to know if it was DK or HHS on this, right?
Yes,
Okay. I got it. Previously healthy 37 woman comes to the physician because 2 year history of her hands and fingers turning blue with cold. The discoloration has been occurring with increasing frequency and now occurs with exposure to air conditioning and cold water. Exam of the hand shows no abnormality. The brachial and radial uh, pulses are present bilaterally. The hands are raised in cold water. The fingers become bluish, then bright red, then rewarming. Then bright red with rewarming. Which of the following is
what is your
subgroup
diagnosis?
or renal?
Yes,
Um, Next step in management.
we will give the drug calcium channel blocker nifedipine easily given. Okay. Vasospasm and the intermittent loss of the blood flow to the distal extremities is implicated, causing Raynaud's phenomenon, resulting in sequential white, blue, and red discoloration of the affected areas of skin. In severe cases, ischemic injury can result in digital ulceration. Raynaud's phenomenon may be idiopathic or associated with mixed connective tissue disease SLE or CREST syndrome. In addition to counseling the patient to recognize and avoid triggers and cold extremities, significant emotional state, initial pharmacological management should be with calcium channel blocking agent long-acting dihydropyridine calcium channel blocker, amlodipine, nifedipine, and recommended because of their efficacy and low risk adverse effect. Patients should be advised to avoid vasoconstricting medications and cigarette smoking. Okay.
Okay, next. 60 men comes to office for routine medical history, hypertension and alcohol use disorder, medication, amlodipine, omeprazole. He has smoked for 40 years and drinks a lot, 12 beers every day. Vital signs are normal. Physical exam discloses no abnormalities. Results of serum studies are most likely to show which of the following. Hmm.
What is
Feel
your
like
diagnosis?
like alcohol use disorder. I don't know.
Yes, alcohol causes which electrolyte to low.
Oh, jeez. I feel like this is a fact that I knew, but I don't remember it now. I knew it at this time, but I don't remember it now.
Mm.
Uh,
According to first aid, I made a mnemonic like
okay.
by using like e- do you know about the uh, dada in Bangla or like brother? If you
Okay.
ask if you ask your tutor, he will understand.
Okay.
Okay,
What? Okay.
what DA like if
Uh-huh.
you can say the dad also. Okay, okay,
That. Uh-huh.
okay. So diarrhea, alcohol, diarrhea, alcohol, aminoglycoside or amphotericin. These drugs, diarrhea, alcohol, aminoglycoside, amphotericin, and the diuretics, DADA or DAAD. You can take it in your way. If you remember these three or four things, then you can easily assess the hypomagnesemia. In hypomagnesemia, usually these like question fits into these three things. There are other causes also, but
Okay. So those are the main causes of
yes,
hypomagnesemia.
hypomagnesemia. And we know that hypercalcemia can cause hypomagnesemia by impairing renal magnesium resorption. So hypercalcemia may be one of the cause of hypomagnesemia.
Hypercalcemia.
Can cause hypomagnesemia by impairing the renal magnesium absorption.
Impairing renal magnesium absorption. Okay.
So these few causes you need to remember.
Yeah. I don't think I remember that, but I just don't. I remember the fact at that point, but
Yes, alcohol.
yeah. Can you read it?
Yes,
Mhm.
hypomagnesemia is a common electrolyte disturbance in the young. Hypomagnesemia is a common electrolyte disturbance. Hypomagnesemia is a common electrolyte disturbance in the general population, particularly among individuals with alcohol use disorder in up to one-third of the population. Hypomagnesemia is frequently asymptomatic but may present with psychomotor signs may present with psychomotor signs and symptoms including depression, lethargy, weakness, tremor, ataxia, seizures. Severe hypomagnesemia may also present with cardiovascular findings such as supraventricular tachycardia, ventricular arrhythmia, and long QT. Torsades de pointes. Hypomagnesemia may induce secondary electrolyte abnormalities including hypokalemia, hypophosphatemia, and hypocalcemia. Hypomagnesemia occurs in alcohol use disorder as a result of poor dietary intake of magnesium, as a result as well as increased kidney excretion of the magnesium. PPI may cause hypomagnesemia. PPI may cause hypomagnesemia as a result of unknown mechanism. Other potential causes of hypomagnesemia include loop and thiazide diuretics, aminoglycoside, and gastrointestinal malabsorption, which may occur in the setting of chronic diarrhea, inflammatory bowel disease, and celiac disease. Treatment is oral supplementation of the magnesium, and severe hypomagnesemia may require IV therapy. Okay.
Okay.
Okay, can have you done your breakfast? Can we take a break?
Now we can take a break.
Okay.